I recently pulled my hamstring in a lacrosse game, and I met with JJ the day after. It hurt to walk, and she said, let's do a body scan. So we figured out that my hips are extremely tight, probably causing my hamstring to be pulled. She immediately said that we need to try needle therapy, and she said that you're going to find immediate results after. And so I said, let's give it a shot, and it only took a few minutes. And immediately when I got up, I could walk with no problem, and I could also lift up my legs, and everything was a lot looser. I've never been to a doctor's where I've seen immediate results like the time I met with JJ. I'm very pleased to meet with JJ, and I'm looking to meet with her soon, and I'm very happy with the work she did on my body, and it was a great experience.
Welcome to the Dr. JJ Thomas Podcast.
Hey everybody, welcome to the Dr. JJ Thomas Podcast. I'm Dr. JJ Thomas. Today's podcast, we're going to do another clinical rounds. And in the clinical round scenarios, what I'm doing is sharing with you guys real life scenarios from the patients that I treat and taking you through the evaluation process, to the treatment process, to the thought process of how we're going to get them back to their activities as fast as possible. Today's rounds is one of my favorite groups of athletes. It's yesterday I had the pleasure of heading up to Penn State to see 4 of my favorite lacrosse players, and one of them had an acute hamstring injury. So injuries like that I love to address, because if you do it deliberately, you can really get them back to play faster than most people really realize. So I'm going to talk you through how we did that yesterday. This athlete, he's an attackman, and what he said to me is that, he said, JJ, he said, I injured my hamstring about 2 weeks ago. I think it was actually in practice. And he's like, I felt like I did great. I felt like I recovered it. I rehabbed it great. I was working with the team guys here. I really felt like it felt 100%. But they had a game on Saturday, so today's Monday. Sunday I saw him, on Saturday was the game. He's like, and during the game I tweaked it again. He's like, I was just about to change directions, and I just felt it grab, and it was like that high hamstring strain on the right side. And so I said, all right, well, let's look at you. So I look at him, and he's for sure limping, definitely favoring it a little bit, not transferring his weight well, and not swinging the leg through well. So we look at him further, and yes, he's tender at the high hamstring, not really swollen, no bruising, and motion-wise, he's obviously very tender into hip flexion. Tender, I say cautious, like as I, he's supine, as I bring him up into hip flexion, you can see him like wincing, like, oh God, I don't want it to stretch. And I can feel the resistance. I also felt incidentally, not incidentally though, but I also felt like a pinching in the right anterior hip as I was doing that. So I said, all right, well, let's keep looking. So I check his external rotation, and external rotation is limited a little bit, a lot actually, and tender. Faber is limited. Internal rotation wasn't too bad, more limited by the hip flexion piece of that. And so I take him to palpation. I'm like, let's see what's going on here. Definitely tender as I strum across that high hamstring attachment, but also very tight at the distal lateral hamstring and in the adductors, especially adductor magnus, as it attaches in that common attachment of the high hamstring there. So with my experience, what I've seen is that oftentimes a true muscle strain is inflamed at that area, right? But what we want to do is think out of the box. Like, how can we, yes, if it's strained there, there's been a stress upon it. How can we take that stress upon it off so that it can heal faster? So what we did was I put them prone. We did dry needling. I let them sit in the lateral hamstring, biceps femoris, and I focused on the distal mid-belly and also the short head of biceps femoris on the outside, because that's where my evaluation led me with palpation and other things. And then I also came up and did, actually I should show you on this. Let's get to this. So let me just get my glasses on. So here's the body. And I'm going to zoom in for you. Here's hamstrings, right? Here's lateral hamstring. And if I remove that, you'll see under it is short head of biceps femoris right there, okay? So I stuck 2 needles in the distal lateral biceps femoris, short and long head, and I let them sit there. And then I came in from the medial side and angled in towards the femur and got medial hamstring up high where it was tender. And then I came in on the medial side, and if you'll see here, this is semitendinosus. I'm going to remove that so you can see under it is semimembranosus, the other part of the medial hamstring. And then under that is this huge, massive adductor magnus. So his limited Faber, his limited external rotation and Faber, I could feel the tension in the adductors in general. So 2 needles coming from medially in towards the femur, letting them sit along these top bands here. And remember, if I move this, I'm going to remove glute max for you so you can see. This is getting in my way. Here's adductor magnus at that ischial tube attachment as well. So it shares that attachment with all the hamstrings. So we needle adductor magnus, medial hamstrings on the medial side, and then biceps femoris on the lateral side. And I left him with needles in for about 15 minutes at a alternating slower frequency, so 3 hertz, and higher frequency, 10-ish hertz, so high-ish frequency, not really tetanus, but approaching that. Alternating so that it didn't accommodate. So that way we got both things. We got blood pumping mechanism with the slow frequency, and we got closer to muscle recruitment with the 10 hertz. And so it alternated those frequencies for 15 minutes. Then we got him up, off the table, needles out, and we had him walk. And actually first I checked hip flexion, which was way better. He still had that pinch in the front rectus femoris, so that's in the back of my mind. But he was less hesitant and painful with that passive hip flexion. And then when we got him up to walk, you could see it was dramatically better. His limp was way reduced. He was like, I can't believe how much better I feel. That for me is one of the best things about our job, is like being able to surprise a patient. Like, he thought he was out 4 to 6 weeks, and now all of a sudden you see that light, like, oh my God, all of a sudden they're like, maybe I can play sooner than I thought. Maybe I'm not gonna be out as long as I thought. And that's exactly right. So I wanted to get him even further with our treatment. So I said, all right, great. I'm so glad that you're doing better, Kyle. Let's get you back on the table. What I did next was I needled the rectus femoris in the front. Now you might be thinking, why would you needle the front for an injury in the back? Remember, all we want to do is take stress off that joint. If he can't hip drive well, so imagine running gait. If they can't hip drive well because their rectus femoris is inhibited or not firing well because of issues or limitations in it, then they're gonna overflex that knee. They're gonna basically overstride. Instead of hip driving, they're gonna overstride or do this. So improving that range takes the stress off the attachment in the back. So I did an in and out pistoning technique of the rectus femoris and a little bit of the quad here, and then I finished those needles and I had him get up again, and he's like, literally his face is lighting up now. He's like, oh my God, I might be able to play. And so I didn't want to push it too much, though. I still want to respect some healing time considerations, but I do want to load him at that point. So I'm like, okay, look, Kyle, we got your range significantly better in just 25 minutes. Your gait is significantly better, you feel better, your hamstring is less painful. Let's see if we can load it now. And honestly, I wasn't sure how this was gonna go, but that's the only way we know, is to start to test it. So I had him grab a light band, we tied it to the table, and I had him do just standing, slightly knee bent hamstring curls. I would have had him sit, to be honest, but I didn't have anything with me at the time. So I just had him do standing, the band is that way, and he's pulling hamstring curls. He used one of those orange super bands at first. Honestly, it was too light. So we went up to a red one. That was much better. I said, do 30 to 50 reps of that. And that's not a lot. 50 reps, sometimes I think people look at me, they're like, 50 reps? If he's gonna run on a field, he's gonna do a lot more than 50 reps of an exercise, of extra working a muscle. So 30 to 50 reps. I had him break it into sets of 10 to 15 though. Do 10 to 15 and then walk. Make sure it still feels good. We have to still test, retest, and make sure that his body is okay with it. And sure enough, it was. So I said, okay, good, Kyle, that was a good thing. I want you to do those every day. I want you to do a couple sets a day of 30 to 50 reps of those hamstring curls, loading it at a decent level, but not at a level that feels like it's outside your capacity and aggravates you. So the other thing I gave him, though, is that pretzel stretch. So I've made videos on this before, how important it is for all these athletes, but this is one of my favorite exercises for the lacrosse players. And it's really, for him, it was to address that rectus femoris tightness. So since it was his right hip, I had him lie on his right side, pull his left knee up, lock it down, and then grab his bottom foot. And then I cue them not to think about bringing heel to butt, but instead think about unscissoring the legs, because I really want to get that hip flexor. Remember, they have to lock this leg down first. If they don't lock this leg down first, then they're going to end up arching their back and they're going to miss that rectus femoris on the front. So lock this leg down, then they can grab, and then instead of knee flexing here, I want them to pull this back. And then, if they can, I want them to roll the opposite way. And then they're going to get a nice stretch in their thoracic region as well, which for these lacrosse athletes, especially attackmen, who are constantly here and here, they have to get out of that. They have to get their rotation out this way. So those were my two, yes, let's go for it, exercises to start working him back into loading. Now, I will say, after he was feeling excellent after this. He's like, I can't believe how good I feel. I'm so pumped. So I said, you know what, let's go try to load it more. We were in the strength and conditioning area, so I said, go hit the hamstring curl machine, see how it is. And I was working with some other guys too, so I said, just go do that and come back. He went over there, and he's gone a little bit, and he came back, he said, you know what, JJ, that felt like too much. 15 pounds on the hamstring machine actually felt like it was bothering it a little bit, so I just stopped. So I said, you know what, I think that was wise. I would say that we can load it more isometrically or with something like BFR than we can isotonically on a heavy knee curl machine. So, but for him, I said, you know what, stick with the bands right now. Go back to your strength and conditioning coach. Go back to your PTs and trainers that you've already working with. Let them know that we loosened up the muscles around that area, which is going to take stress off that hamstring attachment and allow you to return to play faster. Because think about it, the way I described it to him, it's like a scab. Like a strain, a muscle strain or a tendon strain is like a scab. If the scab keeps getting picked off, it's going to take longer to heal. And things that are going to create that scab to keep getting picked off are the other muscles, the other functional unit around that area. So by us coming in and cleaning up the range of motion around that, so cleaning up the distal lateral hamstring, cleaning up the adductors, cleaning up the anterior hip, and then maintaining those range of motion gains through the exercises and reinforcement with loading, we're actually allowing that scab, protecting that scab, and allowing it to heal so he can get back on the field faster. You know, this, in my opinion, is the single number one reason why, other than the severity of the injury, number one differentiator for how fast someone can get back to sport. If we just completely rest and wait for the muscle or tendon to heal, we're missing the boat. We need to facilitate it. We need to support it by making all the other muscles in that functional unit work better. And then they're going to be able to get back, as soon as that muscle's healed, they're going to get back to sport and succeed in it. So that's the story. I had a lot of fun working with him. I know they have a game coming up this weekend again. I'm hoping he can get on the field. I feel like it's definitely a possibility. So stay tuned. I'm looking forward to seeing how he does. And if you have any questions on this clinical scenario or any of the other clinical rounds, as always, I'd love to hear from you. Leave a question in the comments below or just DM me or reach out. Talk soon.